Hello, everyone, and welcome to another NDD live training session. Thank you for joining us. We're always so glad that so many of you come out each and every month to be able to learn about our products and learn just more about how to be a better tester. And today we are looking at the EasyOne Pro and Pro Lab, focusing on the DLCO test. To get started, some objectives from today, we're going to learn how to set up the device for the DLCO test. So there's a couple of things that we have to do when transitioning from spirometry to DLCO. We're going to learn how to coach the patient through that DLCO maneuver. DLCO is sometimes a little bit intimidating, but for our patients, it actually is a much easier test for them. So just learning how to correctly coach them through, learning common test errors, how we can encourage a good test effort from our patients. And then at the end, we will do just an open Q&A. My name is Jamie. I'm a respiratory therapist, and I serve as our global training director and research director here at NDD. And so again, thank you for hopping on. If you do have questions, again, we will absolutely take the last few minutes of the webinar to kind of answer some questions live on camera. However, to get those questions answered, type them over into the questions tab on your GoToWebinar toolbar. We do have somebody else on the webinar as well that's kind of manning that question box throughout the webinar. So some of those questions we can answer as we go, but of course, then we will read from those questions at the end. So feel free, once you have questions, be sure to type them over into that questions bar. All right, so we're going to get started with talking a little bit about the how and the why of DLCO. Why do we want to do it? What can it tell us in addition to traditional spirometry? And DLCO is the diffusing capacity for carbon monoxide in the lungs. This is a true measure of gas exchange. It measures the capacity of our lungs to take up oxygen and use oxygen in our body. And in some areas of the world, you might be more common with the term TLCO. This really is that next step in diagnosis. You know, we know from spirometry if there is an airflow limitation. Does the patient have an obstruction? Do they possibly have a restriction? This is kind of that next step. Now that we know how well or how ineffectively perhaps they can move air in and out of their lungs, we need to see what they can do with that oxygen once it's in their lungs. Are they able to get it to the rest of their body? This is, I always call this is a little bit of the biology 101 portion of the lecture, but it's really important for us all to have kind of a baseline understanding of what we are measuring here. So we know that when we inspire or take a breath in, we're breathing in through our mouth or nose, and it's making its way down the trachea. It has to make it all the way down to the alveolar space, those little air sacs in our lungs. Our trachea goes into our bronchi, which branches into bronchioles, and then that air has to travel 18 to 24 generations of that tree branching in order to make it to the alveolar space where gas exchange actually occurs. The alveoli are the gas exchange surface area of the lungs. It's mostly passive diffusion. Oxygen diffuses into the bloodstream, red blood cells grab it up and take it around the body, and then CO2 diffuses from the bloodstream as waste back through the lungs. And then we kind of do this process in reverse to get rid of that waste. Here's kind of a really close-up picture of an alveoli. Oxygen is transported by those red blood cells. It takes oxygen out, brings CO2 back as waste, and we transport it back out of our bodies. And that is the gas exchange that all of us do all day, every day without even thinking about it. So again, why do we measure DLCO? Again, spirometry, we're looking at flow, how quickly a patient can move air in and out. We're looking at volume, how much of that air can they move in and out. So why DLCO? Why do we go through the hassle of doing this additional test? DLCO results can be used together with spirometry, other exams, patient symptoms, and patient history to reach a much more complete picture of a patient's respiratory health. DLCO can also help with identifying the nature, assessing the severity, and monitoring the progression of a wide range of lung disorders. So we can, of course, use it to assess and monitor the severity and progression of a disease. We can confirm or exclude diseases like asthma, COPD, fibrosis. We can assess an anesthetic risk prior to surgery and monitor the improvement of those on a treatment plan or a medication plan. An amazing example for this was COVID, actually. DLCO is reduced in patients recovering from COVID. We know that COVID is a lung disease. That's what we like. That's where our brains immediately go to. But at its core, COVID is a vasculature disease. It attacks that vasculature in our lungs, which affects how we exchange that oxygen back and forth. A lot of different pulmonary rehab centers, different hospitals, they found that in these patients that are still symptomatic from COVID, 3 months, 6 months, 9 months down the line, a lot of times they can have normal spirometry, but then when we do DLCO, that's where we see the deficit. We take it that one step further and see that, yes, the patient's moving air just fine, but when we get actually down to the nuts and bolts of gas exchange, that's where the issue is. So we started that was an excellent example of how we can use DLCO to give us a much fuller picture of what's happening with the patient. So this question always comes up, whether I'm doing live trainings, whether I am on site with clinics that are training on the EasyOne Pro or Pro Lab, and that's why do we use carbon monoxide? Red flags are supposed to go off when we think about breathing in carbon monoxide, and really the end of it is it has a much higher affinity to our hemoglobin, which means it's much more attracted to our hemoglobin than oxygen. 200 to 250 more times higher affinity than oxygen. So we are able to do this test in a very, very quick 10-second breath hold, where otherwise we would not be able to measure it this quickly. It is a very, very safe test. If your patients ever have questions about breathing the test gas, you get more CO probably sitting in 5 o'clock traffic or 8 a.m. traffic, whichever you are closest to. This is even safe for pregnant women to do. The amount of CO is so minimal, and we do wait between each DLCO trial to allow the body to naturally expel that CO. So there really is not a profound, when doing the test correctly, there's no profound risk to the patient whatsoever. All right, so we know a lot of the, FEV1, FVC, SVC, we have these parameters that are very familiar to us in the pulmonary world. Sometimes the parameters in DLCO are maybe not as well known to us. So what are some common parameters obtained? And of course, the first is that DLCO measurement. So the diffusion capacity or the transfer factor of the lung for that carbon monoxide. How well can that CO be transferred from the blood to the lungs and vice versa? Alveolar volume, the VA. This is the actual surface area of our lungs that's available for gas exchange. You've probably heard the analogy that if you were to spread out the surface area of the alveoli in your lungs, it would be like the same size as a tennis court. There is a lot of surface area wrapped up into those tiny alveoli that are available for gas exchange. TLC obtained from a single breath maneuver. A lot of people don't know that you can get a TLC or a total lung capacity from the DLCO maneuver. It's a measurement that's taken right at the end of the maneuver and gives us a really good single breath TLC without having to do an additional test. The VD or anatomic dead space. The average and what our device applies to the test is 150 milliliters. This is the amount of air that is in and out during a breath that would not be involved in gas state exchange. So the volume, anything from the conducting airways, so your nose, all the way down to the terminal bronchioles as they start to branch. So all of this dead space that is not actually exchanging gas. And then last but not least on this slide, the KCO or the DLCO to VA ratio. So this is defining the diffusion capacity per alveolar volume, per unit of alveolar volume. So out of that entire tennis court, how much is actually exchanging gas? It helps us distinguish between different types of lung diseases. All right, so the testing gas. The gas, there's several different options that are out there depending on the device you use, but all of them have kind of the same skeleton, the same layout. So it should contain around that 0.3% carbon monoxide, 18 to 25% oxygen, a tracer gas, and then balancing the mixture with nitrogen. How do we measure this? That tracer gas is used to determine that alveolar volume through dilution. So that tracer gas should be relatively insoluble to lung tissue, chemically, biologically inert, should be very similar to what CO2 would do. And the most common tracer gases that are used in DLCO mixes are helium and methane. Our device does use a helium mixture. So it has to be that mixture. If you happen to have a methane tank, it will not transfer over for this device. But again, both mixtures are very common out there in the device world. So both gases are really easy to obtain from your local gas provider. All right, so how do we prepare our patients for DLCO? Most of the time, they're not coming in just for a DLCO test. A lot of times there are other laboratory tests, spirometry that needs to be performed, maybe even a multiple breath washout if you have the Pro Lab, maybe you're using a body box, whatever that looks like. A lot of times DLCO is not the only test this patient is doing. So our patient information across the board for our lung tests are the same. So we need their patient's age, their height, their weight, their sex at birth, ethnicity, depending on the predicted value set that you have selected. All of that information is going to be the same. We don't need additional patient information to perform DLCO versus spirometry. Patient positioning and all of the rules that we discuss with spirometry is the same for this test also. Patient should be sitting upright in a stationary chair or standing with that stationary chair right behind them, both feet flat on the floor, chin lifted off of their chest, and any tight clothes should be loosened. Same rules for spirometry, things we can't see, chest binders, abdominal binders, shapewear has become something that we have to kind of ask about now. Anything that's going to prevent the patient from taking a big, big, big deep breath in and holding their breath. Another question we get a lot, I don't have it included on the slide, but somebody always asks, is about dentures. Same for spirometry, for any test. If the dentures are well fitted and secured, by all means leave them in place. The patient's going to be able to make a much better seal on their mouthpiece with those left in place. Obviously, if they do not fit correctly, too big, too small, they're not well secured, the patient would probably have a better time being able to take those out. All right, at a quick glance, this is our DLCO test. I always tell patients this is a much easier test than the forced maneuver spirometry that they have done previously. And there really are only 5 steps. We're going to have the patient breathe normally. We're going to have them fully empty their lungs. We're going to have them fill up their lungs all the way, and then they're going to hold their breath. And then at the very end of the test, when prompted, nice and relaxed, they're just going to let that breath hold back out. So normal breathing, fully empty, fully fill, hold your breath, relax. That's exactly how I explain it to the patients. I always tell them there's maybe a few more steps in this test, but it's really not any more difficult. And I always let them know, not only are we going to coach them through the test, but the device also is giving us the steps one at a time as we go on. So this really does kind of give you the details of the simplified 5 steps that I just talked about. Again, we want the patient to start tidal breathing. The Pro and Pro Lab device does not care how many tidal breaths they do. You'll notice when I play you the video in a moment that the instructions from the coach on the device almost immediately switch to have them fully exhale. But again, we don't care how long they normal breathe on the mouthpiece. We want them to get used to breathing through the mouthpiece. We want to be able to see when they've dipped below baseline on their exhale. So again, I normally have the patients do 3 or 4 normal breaths, just ensuring that they're comfortable. There's no leaks at the nose clip or the mouthpiece while they're doing this. On that second step, we're going to have a maximal exhalation, or we're going to have the patient blow out all their air all the way to the point where there is no more air coming out. So reaching that point of expiratory plateau. We want to limit this time to 12 seconds. For patients who are more obstructed, exhalation is going to require more time. Most of us can empty our lungs fairly quickly, even in a relaxed manner. For some of these obstructive patients, we even might instruct them to blow out a little bit harder so that they can get to that point of plateau within that 12 seconds. I do mention that during this maximal exhalation, we as the technicians on the Pro Lab device have one extra step we need to do. And as soon as they start to breathe out, there's a button that appears on the screen that says activate. And that's just telling the device to watch for that point of expiratory plateau. But you'll see that when we get to the video. The third step is a maximal inhalation, or the biggest, deepest breath in possible. This needs to be within 4 seconds. You can see in my example picture that that line where the number 3 is pretty straight up and down. It really should be a quick inhalation up and above the dotted line that you see on the screen. That inspiratory volume has to be at least 90% of the vital capacity from the spirometry that they did in the same session. That inspiratory time should be less than 4 seconds, and this is where the test gas is actually introduced into the system. Step 4 is the breath hold. It's plus or minus 2 seconds on a 10-second breath hold. We want to make sure that this is a real breath hold, no attempts to inhale or exhale, no breathing through their nose, making sure that it does look really like a plateau. And then, of course, step 5, a nice relaxed exhalation that is smooth, unforced, and without hesitation. So as soon as the countdown hits 0. All right. Before we do this, I'm going to pause sharing my screen for just a moment so that I'm a little bit bigger on your screen. But having to do a screen to a camera is sometimes a little bit difficult. So I actually am going to kind of play you a video that I recorded off of my Pro at an earlier time. But there are a few steps that we need to do on our Pro to transition from spirometry to the DLCO test. So for spirometry, we are just using our purple spirometry handle. You'll notice that I have on my mouthpiece, I actually have it marked, but there is a stamped arrow on one side of, or excuse me, on both sides of the mouthpiece. That's going to be important just so that we know how to mount our gas tubing onto our handle. Just like in our other spirometers, the mouthpieces, whether you are using the traditional Spirette or the filter solution, which is the mouthpiece filter with the Spirette FA, both options have also a stamped arrow on the top that will correspond with the stamped arrow on your purple mouthpiece holder, excuse me, on your handle. So those 2 arrows, sorry if there's a little bit of a glare, those 2 arrows should slide right into each other, making this flush to the handle itself. If you are using the Spirette FA and the filter solution, same thing, the arrow to arrow, you'll slide it all the way in and then place the filter onto the Spirette FA. All right. Just as a note, we do have different different filter solutions for our spirometer. So the spirometry filter that is intended for the Spirette, just remember that is for the EasyOne PC only. The only approved filter for the Pro and Pro Lab devices are the Pro filter kit with the modified Spirette and the filter on the patient side of the mouthpiece. All right, so this is what it looks like when we're set up for spirometry, but once we transition to DLCO, there's a couple of things that we need to know. We will need to have a DLCO barriette. Sorry, trying to get the glare off of there. But the DLCO barriette is an additional filter that protects the device behind the patient mouthpiece, and our motor block for our DLCO. So that barriette is actually going to sit right on top of that one-way valve. And sorry guys, I'm trying to get the glare off of there, and sit in that one-way valve arrow to arrow. Once that is in place, we'll line up the stamped arrows on the spirometry handle and on the motor block, and then slide the motor block into place. All right, we always want to make sure that we do line up those arrows and slide, and the same thing when we remove, we can hit that silver button, line the arrows up before we lift that off. You'll notice inside of the DLCO motor block, there are a couple of pins. So if we are kind of cranking this a little severely, those pins can get bent. So again, it's always really important to line up the arrows and then slide that forward. So now we would be ready to do the DLCO test. So the gas tank should be connected. It should be turned on to the specified amount, which is 5-6 bar on most regulators. I know that we have an international audience here, so I know that not all regulators look the same, but you'll want to make sure that you do have tank volume, which would be 1 dial, and then make sure that the flow rate coming from that tank is adequate for the DLCO test on the other dial. You should only really need to adjust the flow on the tank when you put a new tank on. It will, even when you close the tank, release the gas pressure within the EasyOne Pro, that will spring right back up to where you last had it set when you turn the tank back on the next time. All right, so I have my DLCO barriettes in place, spirettes in place, everything is connected, the gas tank is turned on, and it's ready to use. So I'm going to go ahead and share my screen again with you here, and we're going to talk through the test. All right, so I am selecting the DLCO test. The Pro is measuring our environmental settings in real time with a sensor on the back of the device. So we can take a look at those and press confirm. All right, I'm going to back up just a little bit there. You can see that the filter option for the EasyOne Pro is displayed on the left-hand side. The traditional spirette is on the right. So prior to each test, if you have filter use enabled in your settings, it's going to ask you, are you using the filter solution or are you not? All right. So as soon as we do that, it's going to launch into what we call our true check or our 5-point check. This is checking everything that we need to do prior to the DLCO test. So we're looking for leaks, we're checking the gas composition, we are checking linearity, all of the things that we would traditionally have to do with the big bellow bag on the older DLCO devices is being done automatically during the 5-point check. I a lot of times will use this time to just explain to the patient the test. It normally lasts about 30 seconds. And then once the coaching bar tells us to start, we're good to hand the mouthpiece over to the patient and get started with regular breathing. So as soon as the 5-point check is completed, it will tell us to start the test. All right, so there's the instruction for tidal breathing. I normally, again, have patients do 3 or 4 breaths. You'll notice that the instructions change almost immediately, but the device doesn't care how long we tidal breathe. So we want to make sure that the patient is really used to that mouthpiece. I'll coach them, all right, now on your next breath, I want you to go ahead and blow out all your air. I'm going to hit the activate button. The patient's blowing, they're blowing, they're blowing. As soon as they plateau, the gas comes in, big deep breath in, up and over the dotted line. 4, 3, 2, 1, keeping that tight seal, nice and relaxed, breathing out. All right, we'll let it flip over to the results screen here and talk through a few things in the test. All right. So looking at the test, the first thing you'll see is in the coaching bar, it's telling us that that was a grade A trial. It was an acceptable test quality, but more trials are recommended. So the rules for DLCO are a little bit different than the rules for spirometry, where we have to have a minimum of 3 acceptable reproducible, no more than 8 or 12, whatever it might be at your facility. For DLCO, we always want to have 2 acceptable reproducible trials and no more than 5 tests. It is giving us that 4-minute countdown between trials to allow our patients to breathe out all of the test gas, make sure that they really have reset kind of to a baseline gas composition in their lungs before we start again. A few things to look at here. There is that letter A grade on trial 1. We can customize what is seen here for the provider in the utilities menu so that you can rearrange or put parameters that are most important to you in the order that you would like to see them on the test. You'll see the volume tracing up top. You'll see the molar mass or the gas tracing below. If I sometimes have this question, so I'll go ahead and call it out now. You'll see at the very end of my test, this is me doing this test, that I took a little bit of a breath in at the end. So we like to see these nice little straight lines coming off of our waveform because this vertical green line is where that DLCO measurement is actually taken. If you see a secondary spike after, That is just room air being reintroduced into that sensor prior to it coming out of the patient's mouth. So again, nothing to worry about if you're seeing that secondary spike after the measurement. All right, up in the upper right-hand corner of the screen, again, I apologize, that font is white, so it's a little bit hard to see, but it says session quality. It's saying that that was an acceptable test, but it wants us to do another trial. You can see below here that we do have a place where you can adjust for hemoglobin on the EasyOne Pro and Pro Lab itself. A CBC or an ABG within 30 days of the test, we can go in and type those actual values in. We can have the DLCO adjusted, selected as a parameter, just so that we can see that adjusted for the patient's real hemoglobin as well, if your physician wants to do that. All right, I'm going to pause the video for just a second, and then we're going to come back to watch that second trial again here in just a moment. But we've talked a lot about, you know, we have to do 2, no more than 5. They have to be acceptable, but what actually makes a trial acceptable? All right, so what is the criteria for acceptability? We want to make sure that the volume time graph is showing a smooth and sharp rise. Again, we have 4 seconds to get up and above that dotted line with the patient's biggest breath in possible. But as you can see here, we want to make sure that the inhalation isn't too slow. We want to make sure that there's not wiggles, like they're kind of taking staggered breaths to get up to that vital capacity line. And then the same thing at the end. We want to make sure that the exhalation is nice and smooth. We want to make sure that they don't blast it out hard and fast at the end of the test. We want to make sure that that breath hold is also stable. Again, it should look like that drawing of a plateau. Other things that can affect that acceptability, we want to make sure that on the gas concentration rise, the same thing. We want to see a sharp rise in the test gas as soon as it is introduced. We want to see nice and stable during the breath hold with no wiggles or leaks. And then during exhalation, we just want to make sure that that's a nice, smooth, but rapid exhalation at the end of the test. The inspiratory volume must be greater than equal to 90% of the vital capacity from our spirometry. So if they do not hit or exceed that dotted line, we know it's going to kick out the test. We want to make sure that 80% of that test gas volume is inhaled with that within that 4 seconds. Stable breath hold, 10 seconds plus or minus 2. No leaks, no swallows, no Valsalva maneuvers, and make sure that the sample collection is completed within 4 seconds at the start of exhalation. So in other words, as soon as the countdown hits 0, that they immediately exhale. All right, we know that we have to have 2 acceptable maneuvers. So how do we know that it's acceptable? We also know that it needs to be repeatable. So between these 2 measurements, we want to make sure that the DLCO is within 2 mLs per minute per millimeters together. So those, the 2 milliliter of the DLCO, excuse me, I got tongue tied there for a second, making sure that those DLCOs are almost identical between the 2 trials. Again, we do want to make sure we wait at least 4 minutes. If a patient had a severe airflow obstruction, like, you know, they took the full 12 seconds to exhale, we might give them a couple of extra minutes just to make sure that they have reset to baseline, essentially. All right, we're going to go back now and look at that second trial of DLCO. All right, 15 seconds and start. It does the 5-point check or the tree check exam prior to every single trial. So when you come back, expect to have that extra 30 seconds again while it's checking linearity for leaks, gas composition, checking that CO sensor to make sure that everything is ready for the test. I also, when the gas flushes, that's a good time to tell your patients that that's what the test is going to sound like, because sometimes they do get startled a little bit when they hear the gas come in. As soon as it switches over and the coaching bar tells us to start tidal breathing, again, we would hand the sensor to the patient and instruct them to start breathing regularly. Again, the device does not care how many tidal breaths. So I always have them do 3 or 4, let them know on this next regular breath, I'm going to have you blow out all your air. So fully exhale. Hit activate, patients blowing, 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 they plateau and get a big deep breath in and hold their breath. 6, 5, 4, 3, 2, keeping that mouthpiece in their mouth, a nice, smooth, relaxed exhale to finish the test. And the test does end automatically. All right, it should pop me over to my results screen again here, telling me that that is a repeatable grade A trial. So within that 2 ml difference between the DLCO values, and it was a good test quality. So now the session is complete. So based on 2 repeatable grade A trials, we know that this is a good and accurate result from our patient and can end this session. Right. A few other things about the DLCO test. Patients really don't complain about that the gas tastes weird. Sometimes it can dry out their mouth a little bit. So if other testing that day, allows them to have a drink of water maybe between trials, that can help. If the patient leaks or if they cough, anything that would cause them to take the mouthpiece out of their mouth, the device will obviously kick the trial out. We really do need it to be pretty consistent. But again, patients really do, especially when they're leaving traditional forced spirometry and moving to DLCO, most patients really do feel like this is an easier test for them as a patient. Now, for us, we obviously have a few more things we have to remember, but getting our patients to reproduce the behavior that we need for this test is normally not a hard task at all. All right. All right. Well, this training always goes a little bit faster just because we are just only talking about this one test today. Obviously, we can answer questions about spirometry because that does kind of go hand in hand with the DLCO test, needing to have the spirometry in the same day on the device. But I know that I have a helper on with me kind of manning the question tab. So I cannot remember who is there today, but whoever's there, do we have any other questions that we want to address from the chat bar?
Hi, Jamie. It's Bianca. Thank
Hey,
you.
Bianca.
You've done such a wonderful job. At the moment, I do not see any questions, but we can maybe give it
Wow,
a
that
minute.
would be
But
a
yeah,
first. Yeah, we can give it just a second here. Um, but trying to think about other things with the Pro and Pro Lab devices. One question that we do get sometimes is what is the difference between the Pro and Pro Lab? So the Pro and the Pro Lab are almost identical devices. The only difference is the Pro Lab has one additional test, which is that nitrogen washout or multiple breath washout test for lung volumes. Other than that, the devices are identical. They do the same tests. Everything looks the same with the exception of the lab having that washout test.
so Jamie, we do have a question that has come through. Someone is asking, does spirometry have to be done on the same device or can you do it on another device?
So for this, it does have to be done on this device. In order to set that accurate vital capacity goal for the patient, spirometry does need to be performed on this device. Now, however, if you have an alternate spirometer, whether it's NDD or not, if you have another spirometer for your spirometry exam, that is okay, but you would need to do at least one acceptable trial on this device in order to set that vital capacity goal for DLCO.
Awesome. Perfect. Thank you. I do see a hand raised. I would just ask if you do have a question, please kindly put it in the questions bar so that we can ask it live here.
Yeah,
But no other
absolutely.
questions so far, Jamie.
Yeah. I was trying to think of anything else with the Pro Lab or Pro and Pro Lab. With the purchase of this device, you do get an in-person training session from our team, whether that has to be virtual or preferably on site. You do get that training included. So we get to get hands-on with this device. Again, it does have a lot more functions than a basic spirometer. So we do like to get on site with you guys when you're learning how to use this. We do provide the gas regulators, but you do buy the DLCO gas from your local gas vendor. And the device does come with a 2-year warranty. So if anything should happen to the device, you would be able to have a loaner device from us and while your device was being repaired, either in our Zurich office or in our Boston office. All right. Seeing if there's anything else that has popped in. It doesn't look like it.
It looks like you've answered all the questions, Jamie, today.
All right. Well, that is I could keep talking for another 20 minutes, but I think that if there are any questions, of course, feel free to type them into the chat. Feel free to reach out to me later. If you are viewing this as a recording, thank you again for taking the time out of your day to watch it. I know that there are so many of us globally in different time zones, and so we try to alternate the times around. But even if you register and don't get to attend, you get that recording the next day. All of you who are here live, you will also get the recording next day that you can go back and reference. Um, Keep an eye out, just kind of a little bit of a plug. Next Tuesday, we are actually having a brand new webinar series, kind of the premiere, where we are going to be talking with a couple of amazing spirometry experts in their field who are going to walk through really targeting primary care and non-specialty offices about why spirometry and lung diagnostics is so important. Why we should be doing it, even when it's hard, even when the patients are difficult, why we should be doing these tests and how it can improve patient outcomes and just have a much better picture of your patients for your primary care office. So if that is you, be sure to check out our website. Send it to any of your friends, nurses, respiratory therapists, primary care physicians, nurse practitioners, PAs, anyone who could benefit from a little bit of the how and why spirometry is so important from the clinical experts. So the registration for that is on our website. You probably got an email about that webinar just like you did for this one. So if you're available next Tuesday, absolutely try to jump on or at least register to watch that webinar at a later time, because it's going to be full of a lot of really good information. But if there are still no questions, I will give you guys back 20 minutes or so of your morning, and we will meet here again next month. Next month, we're going to actually be focusing on the Pro Lab device and walking through the SVC test, or the slow vital capacity, and the nitrogen washout or multiple breath washout test to get TLC on the Pro Lab device. So if that is you, or if you want to learn more about that test, be sure to register. And we look forward to seeing you for future webinars. And have an amazing Thursday, and we'll see you soon. Thanks so much.